Welcome back. This is part 5 of Therapy of Infectious and Parasitic Disease. And in this section, we're going to be talking about the aminoglycosides, bactericidal inhibitors of protein synthesis. Aminoglycosides are narrow spectrum antibiotics that we use primarily against aerobic gram-negative bacilli. And the antibiotics that we prescribe under the aminoglycoside classification are gentamicin, tobramycin, and amikacin. These drugs will disrupt the protein synthesis that will cause rapid bacterial death. These aminoglycosides cause serious injury to the inner ears and kidneys. This is especially important to understand as being a severe adverse side effect. And because of these toxicities, the indications of the drugs are really limited. All of the aminoglycosides carry multiple positive charges, and as a result, they're not absorbed from the GI tract, and they have to be administered parenterally in order to treat systemic infections. And in the US, although 7 aminoglycosides are approved for clinical use, again, gentamicin, tobramycin, and amikacin are the ones that are the most common. They are called aminoglycosides because they are composed of 2 or more amino sugars that are connected by a glycoside linkage. At physiologic pH, these drugs are very highly polar polycations. They are going to carry several positive charges, and again, that's why they cannot cross the membranes of the GI tract and be absorbed. They do not enter cerebrospinal fluid, and they're rapidly excreted by the kidneys. Specifically, in terms of the mechanism of action, it's disrupting the bacterial protein synthesis by binding to the 30S ribosomal subunit, which will do 3 things. It's going to cause inhibition of protein synthesis, premature termination of protein synthesis, and production of abnormal proteins that are secondary to misreading of the genetic code. With aminoglycosides, please do not take their adverse side effects lightly. They're very serious, and they can cause toxicity, especially to the inner ears and the kidneys. First, let's talk about the ototoxicity, and then we'll move to the nephrotoxicity, actually. Now, all aminoglycosides accumulate within the inner ears, and they can cause cellular injury that can impair not only hearing, but also balance. Hearing impairment is caused because it's actually damaging the sensory hair cells in the cochlea. The balance is being disrupted because the damage to the sensory hair cells of the vestibular apparatus is occurring as well. Now, the risk for the ototoxicity is related primarily to the excessive trough levels of the drug rather than just excessive peak levels. And when trough levels remain persistently elevated for too long, aminoglycosides are unable to diffuse out of the inner ear cells. And so those cells are exposed to drugs, this drug, aminoglycosides, continuously and for an extended amount of time. Now, it's the prolonged exposure rather than those brief peaks or these brief exposures to high levels that underlies the cellular injury. So in addition to the high trough levels, the risk for ototoxicity is also increased by renal impairment because it is causing an accumulation of the aminoglycoside, or if you're using an aminoglycoside with a loop diuretic, or also if you have excessive dosing of aminoglycosides for more than 10 days in a row. And patients that are on aminoglycoside therapy have to be monitored for ototoxicity. The first sign is that you are going to experience high-pitched tinnitus, and it is largely irreversible. Permanent injury should be avoided, and as soon as you have any slight side effect that is related to the ear or ototoxicity, you should stop the medication as soon as possible. So tinnitus, persistent headache, or even both of those things occurring at the same time. Now, as the injury to the hair cells proceeds, and the cochlear hair cells, hair cells specifically, hearing the high frequency range begins to also decline. And then you're going to lose low frequency hearing as you keep using the drug. The loss of high frequency hearing is first very subtle. And so you wouldn't just be able to notice it offhand. You'd actually have to test by audiometric testing to detect these high frequency losses. Usually the first sign of impending vestibular damage is going to be headache that lasts 1 to 2 days. And after, that patient may complain of nausea, dizziness, vertigo, and they may feel like they're just unsteady. Tell your patients about these vestibular symptoms as well as the cochlear damage so that they can report any initial signs. So in terms of ototoxicity, now you know it has to do with the total cumulative trough levels mostly. And let's move into the nephrotoxicity. Aminoglycosides also can injure the cells specifically at the proximal renal tubules. They're taken up by the tubular cells and they achieve high intracellular concentrations. And just like ototoxicity, it will correlate with the total cumulative dose of aminoglycosides and high trough levels. High peak levels don't really seem to increase nephrotoxicity. Aminoglycoside-induced nephrotoxicity usually manifests as acute tubular necrosis, or ATN. And the symptoms that you're going to notice are proteinuria. You might see casts in the urine. It may produce dilute urine. And you may notice some elevation in their serum creatinine and their BUN levels. Therefore, you should always monitor BUN and serum creatinine. The older the patient is, and if they already have a pre-existing kidney disease, their risk for nephrotoxicity increases. Also, if a patient is on aminoglycosides, which are nephrotoxic, but they're also on other nephrotoxic drugs like amphotericin B or cyclosporine, it's going to increase their risk for nephrotoxicity. The good news is that the proximal tubule cells can regenerate, and as a result, the injury to the cells can usually be reversed after we stop using the aminoglycosides. But there is a significant consequence of renal damage, which is the accumulation of the aminoglycoside itself because it's not being excreted properly, and therefore it has an ability to exacerbate or worsen the risk for ototoxicity. To avoid some of the risks of ototoxicity and nephrotoxicity, you really want to be aware of the serum levels. And we'll talk about the peak and trough levels in just a minute. So in terms of the dosing schedule, systemic aminoglycosides can be administered as a single large dose just once a day, or we can give it in 2 or 3 smaller doses. Now, traditionally, we have used aminoglycosides by administering them in divided doses, given that they are equally spaced in intervals around the clock, for instance, like every 8 hours. But it is common now to administer the total daily dose just once instead of dividing it up. And this is based on evidence. Several studies have shown that once daily dosing is just as effective as dividing the dose, and it's actually probably safer. Because once daily dosing is both safe and effective, and it's easier and cheaper than giving it in a divided dose. Once daily dosing has now, because of this, become the preferred schedule. However, don't be surprised if you do still see it as divided doses, or if you want to use the option to divide the dose, that's perfectly fine too. It's actually appropriate for some of the patients that need aminoglycosides, like our neonates or patients that are pregnant. Patients that are undergoing dialysis or have ascites, you may consider dividing the daily doses. Monitoring the serum levels are going to be very common. The same aminoglycoside dose can produce very different plasma effects depending on your patient. So it's better just to watch. Peak levels also must be high enough to kill the bacteria, but the trough levels have to be low enough to minimize the toxicity risks, which are ototoxicity and nephrotoxicity. So how do we monitor the serum drug levels? We are going to monitor to provide the best basis for adjusting the aminoglycoside dose if we need to. But we have to make sure that we are meeting our goal in producing enough to kill the bacteria. So the peak levels have to be sufficiently high, but again, the trough levels have to be sufficiently low to minimize this ototoxicity and nephrotoxicity. And the monitoring is done different ways, and it depends on the dosing schedule that we use, if we're giving it once daily or in divided doses. If you decide to dose once daily, only trough levels need to be measured. So as a rule, there's no need to measure peak levels, and this is why some people prefer just giving one dose all at once. And then your high peak levels are going to be guaranteed. Typically 3 to 4 times what we would see in a divided dose, actually. Let's contrast this now. When we divide the doses, we need to measure both peak and trough levels. When blood samples for aminoglycoside levels are drawn, timing is also important. When you get a sample for a peak level, it should be about 30 minutes after giving the IM injection or after they've completed the IV infusion. The sampling for trough levels, however, depends also on the dosing schedule, and for most patients that are getting divided doses, your trough samples have to be taken just before the very next dose. This is how you get the trough. But for patients receiving once daily dose, a single sample can be drawn 1 hour before the next dose. And the value should be pretty low. Preferably, you want to see a value closer to 0. We're going to use gentamicin as a prototype and talk about the therapeutic use. So, gentamicin is an aminoglycoside. It's primarily used to treat serious infections caused by aerobic gram-negative bacilli. And primarily, we are targeting things like E. coli, Klebsiella, protease. You can see the list here. We've already talked about the adverse effects pretty much in detail, nephrotoxicity and ototoxicity. Again, very important. Now, in hospitals where resistance isn't a problem, gentamicin is preferred as an aminoglycoside if we need it to use against these type of bacteria. It's pretty cheap, but we can also use the alternatives like the tropomycin and the amikacin. However, resistance to gentamicin has been increasing, and there has been a cross-resistance to tobramycin as well. And so for that reason, if they are found to be resistant to gentamicin and tobramycin, you can use amikacin effectively. In addition to using it against gram-negative bacilli, we can also use it as a combo treatment with vancomycin, a cephalosporin, a penicillin, if we're trying to treat serious infections where we're just not certain about the coverage that's needed, or we know and we need more, we can use it with gram-positive cocci like the Enterococcus species and some of the streptococci and Staph aureus. And you can see it all here on this table. So can be given by itself. If gentamicin, tobramycin are resistant, give amikacin. If you need, you can also give it with vancomycin, cephalosporin, and penicillin. With tobramycin, they have a very similar profile, tobramycin, to gentamicin in terms of how we use it, adverse effects, interactions. But this drug is more active than gentamicin against the P. aeruginosa bacteria and less active to Enterococci and the Serratia species. And you can see that again on this same chart. And we also use tobramycin with patients with cystic fibrosis. Like the other aminoglycosides, it can injure the inner ear and kidneys. So look out for ototoxicity and nephrotoxicity as well. In some cases, tobramycin can also be used for C. diff, associated diarrhea, or CDAD. Amikacin has two outstanding features that are different than the other ones. Of the aminoglycosides, amikacin is active against the broadest spectrum of the gram-negative bacilli, a little bit more coverage. And it's the least vulnerable to inactivation by bacterial enzymes. Because most of the aminoglycoside inactivating enzymes don't affect amikacin, then bacterial resistance is lower than the other ones, the gentamicin and tobramycin. And that's why if we find that there's a resistance to gentamicin or tobramycin, amikacin tends to be an aminoglycoside that you can still use. It is the preferred agent for initial treatments of infections that are caused by aerobic gram-negative bacilli. But in settings where there is resistance to other aminoglycosides, we should actually consider, amikacin. However, if there's settings where the resistance to aminoglycosides are pretty infrequent or very low, then don't use amikacin. Don't just go straight for that one. Use gentamicin or tobramycin first so that we can slow down the potential resistance to amikacin. We want to use it only when needed and preserve it until we do need it. But just like the other drugs in the aminoglycoside profile, it is still toxic to the kidneys and the inner ears. Don't use it in combination with other ototoxic or nephrotoxic drugs.